Chapter 7: Cost, Benefit, and Ethical Discussion. Choosing between spinal fusion and a modern non-surgical program is not only a medical decision, but also a pocketbook and moral choice, because the dollars you spend and the risks you accept stretch far beyond the day of treatment and can shape an adolescent's entire future. A typical spinal fusion for adolescent idiopathic scoliosis in the United States can cost anywhere from $60,000 to $120,000 once you add the surgeon's fee, hospital stay, anesthesia, imaging, physical therapy, and the time a parent must often miss work, costs that insurance may cover only in part. Yet those bills are just the first chapter. Studies show that hardware fatigue, rod breakage, infection, and adjacent segment wear lead 10 to 25% of spine patients back to the operating room within the first 10 years, and each return trip can carry a price tag as high as the original surgery or more, especially if bone grafts, advanced imaging, or intensive care are required. Factor in the indirect costs, extra travel, hotel stays near specialty centers, tutoring to catch up on missed school, counseling for surgery-related anxiety, and the hidden toll on siblings who adjust their lives while mom or dad stays at the hospital, and the lifetime expense climbs well into the hundreds of thousands of dollars, not counting the emotional interest that accrues every time a new ache raises the question, will this mean yet another operation? By contrast, an iterative non-surgical program that blends ScoliSMART reflexive response training, Schroth-based exercises, scoliosis yoga or Pilates, and periodic metabolic testing is usually front-loaded with a 5 to 10-day boot camp and the purchase of a training suit or props, costing perhaps $3,000 to $6,000 up front, followed by ongoing tune-ups, virtual check-ins, and supplement or lab fees that may run $1,000 to $2,000 per year. Sums that are still significant but spread predictably across time and rarely spike into crisis mode. Families who embrace this active approach can budget for therapy sessions much like they budget for a club sport or a musical instrument, adjust or pause when finances tighten, and avoid the sudden cash burn of a revision surgery that insurance might classify as elective repair. More important than the raw numbers, however, is the ethical weight behind them. Is it acceptable to expose a teenager whose spine is still growing and whose brain is still wiring its sense of self to a 15 to 25% risk of decade-long revision when 50-year natural history studies show that most people with moderate curves experience modest physical limits and normal lifespans without ever facing an operating table? In plain terms, should we gamble a child's flexibility, sports dreams, and psychological ease on a path that may demand 1, 2, or even 3 major surgical payments over adulthood, when lower risk options exist that aim to teach the body better alignment rather than bolt it in place? Advocates of early fusion argue that a straighter spine now prevents pain later, but the evidence gap we discussed earlier shows no long-term, controlled proof that fusion beats natural history for comfort, lung function, or life quality, while the complication literature clearly documents large and underreported downstream costs. On the other side, non-surgical care admits that progress is rarely instant and requires daily effort, yet its risks are mostly opportunity costs, time spent exercising, modest recurring fees, and the patience to track curves at regular intervals, trade-offs many families accept for the freedom to swim, twist, play, and grow without metal constraints. From a public health standpoint, pouring scarce healthcare dollars into repeat hardware fixes when lower-cost, participation-based programs can stabilize or improve many curves raises questions of stewardship. Could those resources be better spent widening access to trained therapists, subsidizing metabolic testing, or funding schools to add spine-safe fitness into gym class? From a moral standpoint, the principle of first, do no harm nudges us to weigh real probabilities, not worst-case fears. If the average adolescent with a 40-degree curve has a respectable chance of leading a full, active life with guided exercise and watchful follow-up, then asking that teen to accept an automatic ticket to high-stakes surgery and the non-negligible chance of repeated revisions, edges toward using a cannon to swat a fly. Until science produces clear, long-term trials proving that fusion reliably outperforms whole-body care, the ethical default should favor the option with fewer irreversible consequences, lower lifetime cost, and the greatest respect for a young person's developing body and dreams.